Dear colleagues and friends, welcome to this special edition of UMC Hippocrates webinars. I bring also greeting from UM's board to all of you. First of all, I want to emphasize that the organizers of this webinar is Ola SAUGSTAD. You all know him very well. And let me remind that it was Ola who carried out the breakthrough work on the right use of oxygen for newborns. If you want to know more about his work on oxygen, I recommend very strongly Ola's newly published book, Fighting for Air, which tells us the unbelievable adventure of his research on oxygen and much more. And he tells his story in a very engaging and exciting way. I couldn't recommend it more highly. Ola will be the first speaker, and he will be followed by 4 top experts in oxygen therapy field. But now I'm pleased to leave the floor to the chairman of this webinar, who will introduce the speaker. Please join Noi, president of WEMS, and Gianluca Lista, the scientific coordinator of the webinar. Please.
So can you hear me? Can everybody hear me okay?
Yes.
Yes. So I'd like to start with just a very brief introduction for Ola. He is, as Professor Moretti said, this is a very, in terms of introducing Ola, everybody knows him. I have had many opportunities to speak with him in the past, and I remember some conferences that we had in the Middle East. We still have some pictures of us in Oman from a few years back. Ola is really the pioneer in oxygen research for newborn babies. And he is obviously from Norway, and he is also an adjunct professor at the Northwestern University in the United States from Chicago, Illinois. Ola, please go ahead.
Thank you so much, Joe. Thank you for the nice introduction. Also, Professor Moretti, thank you for your kind words, as always. I will now try to share the screen, and I hope you can see it. There's something covering, so I cannot get the slide view.
Professor SAUGSTAD, you can do it from the top. Otherwise,
from the top.
You can do it from the top, from the beginning.
Yeah, that's right. There it is. So do you see?
Okay, thank you. Yes.
Okay. So again, thank you to UNPS and Professor Moretti and the chairperson for having this seminar. I think it's extremely important topic, and I will give a few introductory words to this seminar. So I'll start out with summarizing the goals of oxygen therapy of the newborn. And this has been very nicely summarized by Valai and Satya and Maximi and Russima recently. First, it's obvious that it is to provide sufficient oxygen to the tissues and to avoid anaerobic metabolism, and also to prevent hypoxic pulmonary vasoconstriction, and to promote the optimal brain and somatic growth. And then I've added myself to minimize adverse effects, which I think every neonatologist is aware of. I think we all know about the dichotomy of oxygen, that oxygen is critical to life, and also that too much oxygen in the neonate can cause oxidative stress, and this may inflict injury to a number of organs, as I've listed here. Now, what is the role of oxygen in the metabolism? Just a few minutes, I will go back to the basic biochemistry, which we learned in medical school. So if we go to the mitochondria, to the electron transport chain, which is located on the inner mitochondrial membrane, electrons are fed into this chain and they're transported from one component to the other, and this results and protons are then pumped across the membrane, and this results in a gradient, which is exploited to produce ATP. Now, what is the role of oxen? Well, it's there to accept the electrons when they're finished going through all these 5 complexes here, and it's reduced to water, as you all know. So oxen is an electron acceptor. Now, we also know that some of these electrons are leaking out, and they're generating reactive oxygen species, ROS. But fortunately, we have defense systems against that, which may neutralize potential harmful effects of reactive oxygen species. During hyperoxia, more of these electrons are leaking out, so they may overwhelm the defense systems. And we also have to add that preterm babies, they have a lower defense than term babies. That is another important aspect of this, and that is the ATP production is reduced. And I'll come back to that, because I think we are understanding some of the mechanisms now, but this might be one reason hyperoxia is detrimental, that ATP production is reduced. So what happens if you resuscitate a newborn with 100% oxen? There's been several studies, both clinically and experimentally, showing that you get a very high PO2 peak, the red line here. This is an experimental study in newborn lambs with cardiac arrest. And you see this very high PO2 peak, which is achieved. The blue line represents the animals resuscitated with air, and you see you get this more physiological, slow adaptation. Some years ago now, Koch and co-workers from Dallas, they exposed newborn mice to 21% or 100% oxygen after brain ischemia. And what they found was that brain injury increased significantly if the animals were exposed to hyperoxia, 100% oxygen, instead of air. So they wrote that hyperoxia is kind of frying the brain. It's very dramatic. So if this is the case for newborn babies who have been exposed to 100% oxygen, it is dramatic. So why have oxygen been so widely used among newborns? I think one aspect of this was that when Virginia Apgar introduced her Apgar score in 1953, they used a lot of oxygen. In her original cohort, 20% of the babies received oxygen. And we know that to achieve a high Apgar score, a newborn baby has to be pink. And there's only one way to make a newly born baby, 1 minute, 2 minutes, 3 minutes, pink, and that is to give oxygen. So for that reason, in many countries, for instance, South America, oxygen was given routinely. A dash of oxygen was given routinely to newborn babies in order to pink them up so that they can get a higher Apgar score. So if we look at the world map for newborn resuscitation, before 1998, it looked like this. All guidelines, as I'm aware of, they recommended use of 100% oxygen. And those countries who didn't have access to oxygen, newborn babies were not resuscitated. So in this period, babies who were resuscitated, they had to go through this toxic period here. They had this toxic oxygen peak. Now, in the 1990s and beginning of the 2000s, several studies show that it's possible to resuscitate with air. And this is a meta-analysis we published in 2008, and showing that if you resuscitate newborn babies with air, there's a 30% reduction in mortality compared with if you resuscitate with 100% oxygen. So this was quite a dramatic finding. And 2 years later, ILCOR changed their recommendation from 100% oxygen till it is best to begin with air rather than 100% oxygen. So subsequently, the world map changed something like this. All guidelines changed from oxygen to air. And babies had this more physiological transition in PO2. What about oxygenation beyond the delivery room? Well, I'm sure most of you have heard about the Neoprom trials, and Professor Lakshmi and Russima will talk more about them, but I just very briefly mentioned that there were 5 studies: the support trial, the COT trial, and the boost trials. And in these trials, babies less than 28 weeks were randomized to a low saturation target, 85 to 89%, or a high saturation target, 91 to 95%. So here I have looked at the risk difference for several outcomes related to high or low saturation targets. And every column above 0 means that a high saturation is favored, and under it's an advantage to be in the low saturation target. So we see here, these are the p-values. So mortality was significantly increased mortality was significantly decreased in the high saturation target, and also necrotizing enterocolitis. The opposite was found for ROP and BPD, and this illustrates the dilemma we are facing as neonatologists to find the right balance between too much and too little oxygen. Just a few words about what I think is important, and that is genetic and epigenetic changes after hyperoxia exposure. This is a study one of my fellows carried out in Bergvall some years ago in newborn mice. They were hypoxic and they were reoxygenated with different oxygen concentrations. And what we found was that genes related to oxidative phosphorylation are downregulated if you reoxygenate with 60 or 100% oxygen compared to air. This may explain why ATP production goes down after hyperoxic exposure. So genes in all the 5 complexes in the oxidative phosphorylation were downregulated in this model. We also were able to show, this was Renat Solberg, another close collaborator of me, when I looked at Krebs cycle metabolites, that mitochondrial function was deteriorated when newborn piglets were resuscitated with 100% oxygen. What about epigenetic changes? Well, this is an illustration from Max Vento's group very recently, indicating that hyperoxia via reactive oxygen species increases DNA methylation, histone modification, epigenetic changes. So we have tested that out in a newborn mice model. So newborn mice were exposed to 85% oxygen for 2 weeks, 14 days, and we had controls in air. And so here we see the mice in their nest. So what we found was that we found DNA hypermethylation in 1,000 genes in these hyperoxic mice. And it was especially the TGF-beta pathway genes that were different. And we know that TGF-beta plays an important role in lung development and also for development of bronchopulmonary dysplasia. So here we see histological picture of these animals exposed to oxen. It looks like BPD. And you don't need to be an expert to see the differences in the heat map between the Hyperoxia and Normoxia animals. So with this, I just want to end with some unanswered questions for newborn oxygenation. And we're trying to answer several of these questions in this seminar. First of all, what is the optimal initial FiO2 for very preterm babies, less than 32 weeks gestation? What should be the oxygen saturation target? And when should it be reached? And to reach the target, should we start with a low FiO2 or a high FiO2? Now, how should we adjust FiO2 to reach the target? And what are the detrimental effects of bradycardia the first minutes of life, especially in combination with low oxygen saturation? And we also today know that there is effect of gender, CPAP, cord clamping on how the saturation develops. So we have to take all these aspects into account when we're talking about oxygen saturation in the delivery room. There are several important conditions in the newborn which have not been studied very well. For instance, primary pulmonary hypertension of the newborn, congenital heart defects, and congenital diaphragmatic hernias. So we need more studies in these conditions. Beyond delivery room, what is the optimal saturation target? Which alarm limit should we aim at? And should saturation target change according to gestational age and maturation? And how should we avoid fluctuation? Should we use automated closed loop control of inspired oxygen concentration? I think that is the future. And what are the long-term effects of hyperoxia in the delivery room and newborn period? So with this, I will end. I thank our distinguished lecturers today for their willingness to present today. Max Vento from Valencia, Satya and Maximi Russima from Davis, US, Julie Ovi from Sydney, and Vishal Kapadia from Dallas, Texas. So with this, I will close. And for those who are interested in my biography, which is now soon will be published in English, here's an email address where you can pre-order it, and you will receive it as soon as it's been published. Thank you very much for your attention.
Thank you, Ola. That was a wonderful introduction. I am just amazed at the importance of oxygen early in life, and I think that some of the aspects that you're bringing up about the epigenetics really underline how important this is for the lifetime of the individual, and even beyond perhaps the importance transgenerationally. So thank you very much for that introduction. Professor Moretti, I think you're going to introduce Max.
Max is
I introduce
Gianluca Lista.
Good morning,
okay.
everybody. Before to move to the second speaker, I want to remember to the audience that you can use the session DNR, question and answer, to send a question, and at the end of the discussion, we collect all the question to the speakers for the discussion. But I move to the second speaker. The second speaker is Professor Maximo Vento. He's a very good friend. He's a professor of pediatrics. He works in Valencia, Spain. He's a chairman of the European Board of Neonatology. He's the chairman of the Spanish Maternal and Child Health Network, and he was a past president of the Spanish Neonatal Society. He's very active in the research, and I know that one of the most important field of research is the neonatal transition, particularly the effect of the oxygen in the transition, both for the preterm infants, for the term infants, in particular for the asphyxiated term infants, and its effect on the oxidative stress. So his talk today is the oxygenation during resuscitation. Please, Maximo.
Thank you. I will try to share my slide now, my slides. Yeah.
Can you put it in presentation mode, please?
Sorry. I had my, excuse me.
No problem.
Yeah, I have to go to the first slide. When I try to put, no, I cannot, yeah.
You can do it.
Yeah,
from the bottom.
now it's fine. Now, okay.
Okay, good.
Can you see it? Yeah, okay. Sorry. Well, first of all, I would like to thank the organizing committee for inviting me to this very special session. I think that oxygen still keeps a big attraction amongst neonatologists, and most probably this is because we haven't been able to solve the problems that oxygen is dealing with preterm babies and term babies. So I will give an overview, and some of the things I will say along my presentation have been portrayed by Dr. SAUGSTAD, and some will also be portrayed by the rest of the speakers. But I would like to see that, to touch what I think are the most relevant points. So what we are talking about is from a fetal neonatal transition. All of you know that in utero we have a low oxygen environment, and delivery is an abrupt event that happens in few minutes. And during this fetal to neonatal transition, we have a drastic increase of oxygen. And we have also what we call a physiologic oxidative stress. This increase of oxygen generates free radicals of oxygen and also of nitrogen, which are essential for the activation of many metabolic pathways. However, we can face two different situations that are not considered normal. One would be a situation of hypoxia, a prolonged hypoxia that could lead to hypoxemia and bradycardia, and give rise to intraperiventricular hemorrhage or even mortality. And we can also have the opposite situation, which be hyperoxia. Hyperoxia, as Dr. SAUGSTAD said, is a true generator of free radicals that are going to cause direct damage to cell structures, but are also going to activate certain pathways like pro-inflammatory pathways, pro-apoptotic pathways, and cause also epigenetic and genetic changes. So the balance between hypoxia and hyperoxia is something that when you are facing a newborn in the delivery room, you should try to solve as efficiently as possible. In 2010, together with a group of Melbourne, we set up reference ranges for the newborn infant. As you see here in the slide on the left, you have the reference ranges for the term infants, and in the right side for late preterm infants. In the 360 babies that we studied minute by minute saturation and heart rate, only very few were below 32 weeks of gestation. So when we are speaking about SpO2 reference range, we are referring especially to late preterm infants. So when we when we try to see the time needed for stabilization of a term infants, you see that to reach an oxygen saturation of around 85%, which is the mean of this saturation range references, we need around 3 to 4 minutes. So this would be a very important fact that we should take into account. Remember, between 80 and 85 at 3 to 5 minutes. When we are speaking about preterm infants, with the same targeted saturation would need around 3 to 4 minutes when we are talking about late preterm. Our experience, however, in the very preterm infants below 32 weeks is somewhat different. So this is the reference range we just put forward and was published in 2020. And this is the reference range in blue that you obtain in term infants when you are having a normal delivery. In normal delivery with delayed cord clamping, what you see is that you get higher oxygen saturations much earlier and higher heart rates much earlier. And this is something that we should be taking into account when we are going to do the new guidelines in the coming years. So now you see from 3 to 2 minutes, not even 2 minutes, is what it takes a normal baby with delayed cord clamping of more than 2 minutes to reach an oxygen saturation of 85. The studies that Dr. SAUGSTAD initiated and were published first in 1993 in Pediatric Research, a small feasibility trial, and afterwards the research trial in which I was really very happy and very fortunate to participate, we're trying to compare resuscitation of term newborn babies with asphyxia and comparing room air 21% oxygen versus pure oxygen or 100%. And this was the room air 2 study in which we enrolled 300 babies, 288 with room air and 321 with 100%. As you can see in this slide, in the middle panel, the beats per minute, the heart rate wasn't different between babies receiving air or pure oxygen. However, there was a tendency to a more prompt recovery, and the Apgar score in the group of room air was somewhat higher, significantly higher at 1 minute, and not different, at least statistically seen, but it was somewhat higher at 5 minutes. What does it mean? It means that babies with being ventilated with room air initiated respiration earlier than babies that receive 100% oxygen. When we analyze the data of the blood gases and acid-base status, what we see is that there were no differences initially, but when babies were resuscitated with oxygen, their PO2 was higher than at 10 minutes and much higher at 30 minutes. So they remain in a relative hyperoxia to babies with room air for a long period of time. We didn't find any significant differences, although we found a tendency regarding death within the first week, neonatal death in the 28th day, or HIE grades 2 or 3. We performed a similar study, but the differences between the room air study now and our study is that for the first time in the delivery room, we were able to blind babies for the amount of oxygen or for the FiO2 they were receiving. So our people in the delivery room were giving a gas admixture without knowing exactly what they were giving, if they were giving room air or pure oxygen. They just control the outcomes through the pulse oximeter. And as you see here, our results coincided with the research to study in which the babies in the room air group were able to start breathing earlier than the babies in the 100% oxygen group. But one of the most striking findings that we had is that we analyzed antioxidant enzyme activity, and we also analyzed reduced versus oxidized glutathione, which is one of the main markers of the redox status of the cells. And redox status signifies that cells with a normal redox status are going into reproduction, into complexity, and into metabolism much more normal than cells that are in a hyperoxic or hypoxic redox status. And what you see here is that babies that receive room air in the squares, in the white squares, had an oxidative stress immediately after birth, but then recovered and were no different to babies that were non-asphyxiated controls. However, babies that received high oxygen concentrations behaved similarly to the babies that received room air, but kept in a pro-oxidant status for several weeks after resuscitation. The meta-analysis that was mentioned by Dr. SAUGSTAD was done with a series of studies that were performed between 1993 and 2007, altogether more than 2,000 babies. We had randomized trials and we had quasi-randomized trials, and the final result showed that, here you see it in the red circle, that mortality was reduced and the tendency towards hypoxic ischemic encephalopathy was also reduced, although not significantly. From then on, 2010, room air is recommended for term babies. What happens with preterm babies? Well, we have still many questions that should be answered as Dr. SAUGSTAD proposed. Initial inspired fraction of oxygen, saturation targets, consequences of not achieving targeted saturations or not keeping the heart rate within normal limits, or should be adjusted from an individual point of view. Each neonate, should we have a specific procedures for each neonate according to his gestational age, to his sex or gender? Sex is a biological issue, type of delivery, etc. So all these questions are needed to be answered. There have been different studies that have started with different FiO2s and have compared high versus low FiO2 for preterm babies in the delivery room. What I wanted to underscore in this slide, and this a new slide that I have been looking at, is that if you look closely to the different studies that were done by different researchers, our group in 2008 in this blinded study, Rook et al. in Holland in 2014, also a blinded study, or Kapadia et al. in Texas in 2013, you see that there is a tendency for most of the babies to reach a stabilization around 40, 50, 55 FiO2, percentage of FiO2 around between the 3 and 5 minutes. You see it's reproducing in all the different trials. If you are starting with a high oxygen concentration, you reduce it, and if you're starting with a low one, you increase it. But around 3 to 5 minutes, most babies feel comfortable with an FiO2 of 0.4, 0.5. This is the study by Julie, who is today one of the speakers today. And you see a similar thing that I previously described. Starting with 100%, you have to reduce, because if you don't reduce, your saturations get too high. And if you are starting with a low, then you increase. And this is something that is happening with babies, all babies included, less than 32 weeks, or even in the smallest babies. So, however, what the study, the Torpedo trial showed is that if you initiate with room air in very preterm infants, let's see here on the right panel, less than 28 weeks of gestation, it is very difficult for you to achieve a targeted saturation of 85 before you reach the 7th or 8th minute after birth. And this time, while you are being below the saturation that you are targeting, it can coincide with alterations of the heart rate. If both situations are concurrent, then you are putting this baby perhaps at risk of having severe complications. And this is something that in the Torpedo 2 trial, we want to study. I remember that our studies were always done with 30% as initial FiO2. And this is a big change in the results. This changes a lot results. Dr. Oi and his group also showed that when babies that are below 28 weeks of gestation are resuscitated or initially ventilated with room air, they have a higher tendency to mortality that is highly significant compared to babies that were initially ventilated with 100%. And when we are studying the new, there has been a new trial going on in Leiden. Dr. Decker from the group of Ari and Tipas wanted to start with, to compare starters with 30% versus 100%, with the idea of giving a push of high oxygen initially to start the baby breathing, stimulate breathing, and then go down rapidly in order to stabilize him without receiving too much oxygen. These are these studies show the FiO2. You see here babies with 100% that is rapidly reduced. And as I showed you before, babies who were started with 30% needed an increase in oxygen, and around 4 to 5 minutes, these babies were around 50 to 60% of FiO2. The difference between both groups is on the right panel, you see the SpO2, is that giving 100%, you reached the nomogram saturation ranges quite rapidly, while when you were using 30%, you needed at least 5 to 6 minutes. However, they didn't find any differences in heart rate, they didn't find any differences in mortality, or they didn't find any differences in complications like ROP, BPD, etc. This is reflected here. The differences that they showed, they found the most striking differences they found is that a high push of oxygen in the first minutes of life caused a more intense rhythm of respiration with higher tidal volumes and higher mean inspiratory flow rates and a reduced time of mask ventilation. However, the differences in the relevant outcomes, such as death, IVH, etc., weren't different. So this is something that has to be again looked with a higher number of babies and I think doing a more intense follow-up to see if the high push-up of oxygen has any consequences. There has been 2 big studies that have been that have reviewed the initial FiO2, and this is the Cochrane review done by Dr. Kilui, who is a colleague of Dr. Oei in Australia. And this Cochrane review compared the mortality of near-term corrected age or at discharge of babies that premature babies that received lower, and lower defined as less than 0.4 FiO2 versus higher, which was more or equal than 0.4. And as you see here, they didn't find any differences regarding mortality. The follow-up of these babies also didn't show any differences in the neurodevelopmental disability after 2 years, although the tendency was towards a tendency toward improvement in babies in the lower oxygen group. Another study, updated review and meta-analysis that was published in 2019 by Dr. Welsford et colleagues, also compared initial oxygen concentrations for preterm infants. And what they show is that they studied that they compared groups of lower initial, they defined it as less than 0.5 FiO2 versus higher initial, which was more than 0.5. And the primary outcome was all-cause short-term mortality or in hospital or at 30 days. That was the primary outcome, and there were several secondary outcomes that I won't describe now. There were different approaches to analyze the data. This is, I think, very interesting because when they looked at the studies that had a lower risk of bias, and you have here the list of studies, you see that there is a tendency to improvement in babies in the low FiO2 group. However, if you look at the high risk of bias, which is the study Torpedo one, then you see that there is a tendency that favors high FiO2. And this is very important because most of the low risk bias were performed in centers with research capacity and with experience in titrating oxygen and using lower oxygen as initial FiO2. The total events considered didn't find any differences. So this is something that I think should be studied, especially in the Torpedo 2 trial. We should be aiming at resolve this issue, because this doesn't have really an explanation, at least at the moment. When we studied blinded studies, which were performed mostly also in places where we had used experience, we had a big experience in doing this type of trials, we also find better outcomes with lower oxygen. And when you were studying unblinded studies in others, then you didn't see that difference. So there must be something in the methodology of resuscitation or in the experience of the resuscitating team that is not only oxygen, it's something else that seems to influence results. So they find out that their conclusions was no benefit or harm for short-term mortality. Long-term mortality also, there was no benefit or harm, and there seemed to be a benefit of lower versus higher FiO2 in observational studies. And long-term neurodevelopmental impairment, they didn't find any differences at all. So what you see here is that independently of the studies and independently of the results, what they found always is that babies in the low oxygen group needed some oxygen supplementation to achieve targeted saturation and avoid bradycardia, while babies in the higher oxygen group oxygen had to be reduced in order to avoid hyperoxia. So these further studies I needed to assess the optimal initial FiO2 saturation targets and titration procedures in very preterm infants are needed. We need to achieve targeted saturations in the delivery room. Target saturations usually are between 80 and 85 at 5 minutes, what we have been deducing from our studies. This was a study in which we cooperated with all this list of researchers, especially Julie O.A. from Sydney and Dr. SAUGSTAD also. And as you see here, neonates who didn't reach SpO2 of 85% at 5 minutes have a higher odds ratio for death, 2.4, which is 2.4 times more probability of dying than babies who did reach that saturation. There was a 4.5 odds ratio for IVH, more than grade 3, and we didn't find any differences for BPD. When we did adjustments for different confounders, what we found is that death was at 5 minutes in babies who didn't reach 100%, 100 beats per minute was 4.2. So heart rate is an essential marker of outcome. And when you look at 5 minutes saturation less than 80%, there was a 4.5 odds ratio for IVH. The Bradycardia study will be presented by Dr. Vishal Kapadia, and I will only briefly mention that this study was done in around 500 babies, and those babies who had a prolonged bradycardia, defined as less than 100 beats per minute for more than 2 minutes, they had a higher probability of dying, having IVH, or for both. And when you combined prolonged bradycardia, more than 2 minutes, less than 100 beats per minute, with low saturation, which means less than 80% at 5 minutes, you had the worst possible situation for your babies. And these babies should be especially looked at in the NICU because they are at high risk of severe complications. I just find my last slide. I conclude that there are no differences in mortality and or severe acute or long-term consequences between using higher 0.4 or 0.5, depending on the studies, or lower, less than 0.4 or 0.5 initial FiO2 in the stabilization of very or extremely preterm infants, as we have assessed in the studies that are available up to date. Babies in the lower oxygen group, especially very preterm infants initially receiving room air, need more frequently oxygen supplementation to achieve postnatal stabilization. Most of the studies showed an FiO2 between 0.4 and 0.5 is needed between 3 and 5 minutes after birth to achieve targeted saturations of 80 to 85%. So this is a hint for the resuscitation team to correctly adjust the FiO2 if these saturations are not being achieved at least at 3 minutes, sorry. And achieving saturations of 80 to 85% between 3 and 5 minutes and keeping heart rate above 100 beats per minute reflect a good stabilization process. And we have done some suggestions. We would suggest infants to start with room air, late preterm also, between 29 and 32 weeks, depending on the status and the response of the baby to initial ventilation. Between 28 weeks, we would recommend starting with 0.3, or even in the smallest ones, in very, very frequently, you will need to switch rapidly to 0.4, because if you don't do so, you won't achieve 80% at 5 minutes. And this is my team, my research group, and I thank you all for your attention.
Thank you very much, Maximo, for your elegant presentation. I think that's still remaining intriguing what happens with the oxygen for the asphyxiated term infants and for the preterm infants, and probably we need much more research in order to understand which could be the optimal FiO2 to give to this baby and which is the optimal saturation. Thank you very much, and I leave the microphone to Joseph to presentation the next speaker.
Thank you, Gianluca. That's an excellent presentation, Max. Our next speaker, Dr. Julie Wei, is from, she's a neonatologist at the Royal Hospital for Women and conjoint professor in pediatrics at the University of New South Wales in Sydney, Australia. And her areas of research are in neonatal resuscitation and in perinatal drug use. Julie is the PI of the Torpedo study, which Max has just mentioned, which is an international multi-center randomized controlled trial to determine the best initial oxygenation for preterm babies needing resuscitation. Julie will talk on the impact of the SpO2 in the first 10 minutes of life. Julie?
Thank you, Professor New. I'll share my screen now. Okay, good evening, everyone, and hello from Sydney, Australia. And that is the view outside my place when it's daylight. It's now 1 a.m. I would also like to thank Professor Ola for his wonderful mentorship over the last many years. So my job is to talk about the role of oxygen saturations during the first 10 minutes of life in preterm infants. So there's two parts to our oxygen question here. So not too long ago, we were told that oxygen could only be good, so use lots. And then Ola and his team burst into this scene in the early 90s with the REST-AIR group of studies that was the first to randomize term and near-term hypoxic infants to either air or 100% oxygen when they needed respiratory support in the delivery room. These studies were paradigm changing and led to a meta-analysis by Peter Davis's group from Melbourne that showed that using air decreased the risk of death in hypoxic term babies by up to 30%. From then on, our resuscitation guidelines changed dramatically. Before that, our standard approach was to use 100% oxygen, as all the other speakers have said, for years and years if a baby needed respiratory support. However, from 2005, it was suggested that room air or 21% oxygen could be used, but that oxygen had to be available if the baby didn't get better by about 1.5 minutes of life. But in preterm infants, there was no information, and resuscitation guidelines recommended that oxygen should be used with caution because of the risk of oxidant injury. So remember, the air and oxygen term infant studies at that time did not blend oxygen as we do now or monitor oxygen saturations. As mentioned before by Max, Jennifer Dawson's team and him and a group of other investigators, there are derived normal SpO2s for healthy term babies in about 2007. And what this group found was that healthy, spontaneously breathing term infants took about 6 to 7 minutes of life to achieve oxygen saturations above 90%. They weren't born with high oxygen saturations. If they were a bit younger, the moderate to late preterms between 32 to 36 weeks, they took a bit longer, about 8 to 8 minutes of life. But if they were even more premature, they took longer, sometimes up to 9 minutes to reach oxygen saturations above 90%. But this study only collected 12 babies who were below 32 weeks who were spontaneously breathing. So this is a very brave study led by the Danish group in 1995. And they examined what oxygen saturations were like if preterm babies were resuscitated with either air or high oxygen, in this case, 80% oxygen. So in this graph, okay, I can show my arrow here. The left axis is the SpO2 and the bottom axis is the minutes of life. And what they did was they looked at 12 babies who were about 28 weeks gestation, who were given respiratory support with 100%, 80 to 100% oxygen, the green boxes, and compared their oxygen saturations to 12 28-weeker babies who were resuscitated with room air. These babies' oxygen saturations were compared to the XPO2s of term healthy infants in blue. As you can see, if the babies were resuscitated with oxygen, they had very high SpO2s as soon as they were born. But if they were given air, the red boxes, they emulated the SpO2s of the healthy term infants. The good thing about this study is that nobody died at resuscitation. They all made it to the NICU alive. But the babies who were given high oxygen, the green boxes, had lower cerebral blood flow. Again, no one died, but in animal studies, lower cerebral blood flow is associated with an increased risk of death. So our resuscitation guidelines changed again, based on evolving information about the first 10 minutes of life and SpO2s. And if you note here, the 2010 guidelines have included targeted pre-ductal oxygen saturations. We were advised to adjust the amount of oxygen we gave to all babies to meet this pre-ductal SpO2 levels derived from healthy breathing full-term infants. And the important thing about this algorithm is that oxygen's gone. However, in 2015, there was a further update and oxygen came back. So it was suggested that we use 100% oxygen if positive pressure ventilation was needed with chest compressions, and also to monitor SpO2 and give supplementary oxygen as needed. All very vague. So in summary, the 2015 guidelines recommended that for term babies, because of the strength of evidence from about almost 20 years ago, to use air to resuscitate term babies. But for preterm babies, you could start with either air, 0.21 FiO2, up to 30%. Don't use more than 65% because of risk of oxidative stress, and to change your FiO2 to reflect normal term baby SpO2 levels. However, if you were in trouble and the heart rate of the baby was less than 60 despite adequate ventilation, if you needed cardiac massage, increase your FiO2 immediately to 100%. The latest guidelines recommend nothing different. So what happens if we don't do what they say? And really, we don't. We always follow guidelines. In 2015, we surveyed more than 600 clinicians from 25 countries and found that almost all of them would initiate stabilization of preterm infants with an initial FiO2 below 40%. Almost none would use more than 60% as recommended by the guidelines, and almost all would target SpO2s suggested by the guidelines. And the brave 4 who said they would use 100% oxygen did so because they didn't have access to oxygen blending or monitoring equipment. So this is a Torpedo study that Max and Ola spoke about. Ooh, my slides moved by themselves. And it aimed in 2007, almost 15 years ago, to see whether the recommendations of the guidelines at that time to use air instead of 100% oxygen could reduce the risk of death and major disability at 2 years. We randomized babies to initial air or 100% oxygen and change FiO2 to meet the pre-specified SpO2 targets. At that time, we didn't have the Dawson curves or any other curves. So we came up with these targets of less than 65% before 5 minutes and less than 80% after 5 minutes. We were very ambitious, and our sample size was almost 2,000 infants to show a 20% reduction in the relative risk of death and major disability at 2 years. However, this was all in vain because, as our timeline shows, the resuscitation guidelines changed in 2005, which prompted the Torpedo study concept. We achieved funding in 2009, and unfortunately for us, the resuscitation guidelines changed again, which coincided remarkably well with our recruitment phase. Because of that, almost all clinicians were reluctant to use 100% oxygen after change to the ILCO guidelines in 2010. So the DSMC, or the Data and Safety Management Committee, got sick of us and recommended that we stop recruitment in 2014 at 15% of our target population, our target sample size. However, they suggested that we reported short-term outcomes because the primary outcomes would take 2 years more. So this is our flow chart. Out of 6,000 eligible babies, we even had 2 that withdrew their consent after they were randomized to 100% oxygen on the advice of their clinicians. We randomized 290, an equal number, to air and oxygen. And I'll first show you the graphs that Max has shown before. So these are the oxygen saturations of the babies who were randomized to high oxygen in black on the top and to air, initially gray, on the bottom. And as you can see, the oxygen saturations of the babies who were given 100% oxygen first went up very quickly and reached about 90% at about 8 minutes of life. Those who were given air first and titrated up with oxygen met these oxygen saturations about 7 to 8 minutes of life. No baby died during resuscitation. But how did these oxygen saturation curves compare to what we are suggested to do from the Dawson curves? If you extrapolate the Dawson curves onto these oxygen saturations, you can see that the only babies that tracked along the curves are the ones who started on high oxygen, 100% oxygen, which no one of us would do nowadays, as we say. And if you split these babies into two groups, in red, the ones below 28 weeks who have sicker lungs, and the ones above 28 weeks with supposedly better lungs, what we found was that the larger babies, or the more mature babies who were given high oxygen, had oxygen saturation levels significantly higher than those that were recommended by the by the resuscitation guidelines. Whereas the tinier babies, the ones with the sickest lungs, had oxygen saturations that tracked along recommended guidelines. But no baby died during resuscitation, as we said, but when we did the post hoc analysis, what we found was that the babies who were started on air and below 28 weeks, the smallest babies, had a 4 times increased relative risk of death compared to the babies who were given 100% oxygen. No infant in our study who was above 29 weeks died. So does starting with lower FiO2 really make a difference? There are 11 RCTs so far that looked at lower and higher oxygen to start off resuscitation of preterm babies. No study has used FiO2 between 0.3 to 0.4, which is what most of us would normally start a resuscitation of a preterm infant. So as Max has said, I'll quickly whiz through these results. The individual patient meta-analysis of these studies showed that regardless of whether you start an infant on low or high oxygen, makes no difference to the risk of death. It makes no difference to the risk of death if the babies are very tiny, below 29 weeks gestation, and it makes no difference to the risk of complications such as bronchopulmonary dysplasia. However, that is probably not the end of the equation, and we need to talk about SpO2, the other oxygen modality during resuscitation. So this is just a reminder of the SpO2 targets from our from popular recommendations, and focus on the 5-minute SpO2, because by the time you get the SATS probe on and everyone's settled, it's probably 3 to 4 minutes of life. So the most common recommended 5-minute SpO2 targets are 80 to 85%. So is there anything magical about that number? One of my fellows looked at SpO2 targets from many countries around the world several years ago. And what he found at that time, probably around 2017, this is published in ACTA, was that the SpO2 targets varied significantly. We have the American Heart Association targets, which is 80 to 85%, which most of us use around the world. And then you have the Scandinavian targets that go as low as 70%, and the Australian and New Zealand targets that go as high as 90%. The RCTs that we have based our practice on all have different targets. The only ones that were conducted during or after recommendations, after the recommendations changed from ILCO in 2010 were from Marta Agua and Vishal Kapadias. And as you can see in this blue box here, the 5-minute SpO2 targets of all these studies varied widely from 75% to 95%. When we looked at each of these trials and we got individual patient data, what we found was that only a quarter of the babies under trial conditions could reach their study targets. They were also 2.5 times more likely to reach that nominal SpO2 target of 80% if they were started on the higher oxygen arm. But what was the consequence? If the babies didn't reach the minimum target of SpO2 of 80% by 5 minutes, they had lower heart rates by about 8 beats per minute. Vishal will speak more about that afterwards. But what was the consequence of that? No one died again. What we found was that babies with SpO2s below 80% were more likely to die and more likely to have an IVH. But we couldn't find from this retrospective studies whether the sick babies died because they were not given oxygen, even enough oxygen, or because they were sick in the first place. We also had a question about the survivors. So what happened to our Torpedo babies? Remember, the aim of Torpedo was to look at neurodevelopmental outcomes at 2 years. And when we followed the Torpedo babies, we could find about 200 of survivors. What we found was that the risk of death or major disability at 2 years, as you can see here, had no difference whether the babies were initially resuscitated with lower or higher initial oxygen. However, if the babies did not reach an SpO2 of 80% at least by 5 minutes of age, they were more likely to die or have a major disability. And, the risk of death was significantly more, especially if they were between 28 to 31 weeks gestation. The impact on neurodevelopmental outcomes were more apparent in the more mature babies, 28 to 31 weeks gestation, who did not reach a 5-minute SpO2 of 80% and above. Remember, we failed to recruit enough patients for Torpedo, so all our results need to be taken with a grain of salt. So we involved other studies, including Denise's Rook's study from the Netherlands, who recruited almost 200 babies below 32 weeks to initial resuscitation with either 30% or 60% oxygen. Nuria Boronet's study from Spain, who recruited almost 60 babies below 29 weeks to initial resuscitation with 30 or 60% oxygen. And we included them with our Torpedo babies. And what did we find? Individually, each of these studies showed no difference of the impact of FiO2 on long-term neurodevelopmental outcomes. So we amalgamated all these studies together and had a total of 377 babies who completed a Bailey test at the age of 2 years of age. So again, what we found was whether you started the babies on lower or higher initial FiO2 had no effect on disability or death. Whether they were started on lower or higher initial FiO2 also had no effect of disability in the survivors. However, if you looked at the magic number of 5-minute SpO2 of 80%, what we found was that the babies who had lower SpO2 had an increased risk of disability and death. And this effect was particularly evident in boys, not so much in girls. And girls who were given high initial FiO2 had the best cognitive scores. Boys who were given low oxygen and did not reach an SpO2 of 80% by 5 minutes had the worst cognitive scores. So time is running out. Many questions remain. Is it the starting FiO2? And what about SpO2? Oxygen blending equipment and monitoring equipment is very expensive and many countries can't afford it. But then again, if we can afford to provide neonatal intensive care, death and morbidity is also costly. So we have more studies planned, and as Ola and Max have mentioned, the Torpedo 2 study, or now known as the Torpedo 30/60 study, aims to compare the outcomes of babies up to 29 weeks gestation who are randomized to initial FiO2 of either 60 or 30% oxygen. These babies have their oxygen adjusted to reach a common SpO2 target until NICU admission, and the primary outcome is survival free of major brain injury. In Australia, we have received consent waiver, and the study is recruiting in at least 6 other countries in the world. So if you're interested in joining, please email me. So we aim to recruit up to 1,500 babies in either arm to show a 25% relative risk reduction with an 85% power, 5% significance in outcomes. So the other study that we have planned is the air study, which is aiming to look at either air or 30% oxygen as the initial FiO2 for respiratory support of the 32 to 36 week infants, which is a very neglected population in our neonatal cohort. So with all our studies that we've done so far, this is a population that has never been studied. So we aim to base it, because it is such a large population, on registry-based outcomes, with a primary outcome of death and admission into an NICU and duration of respiratory support. So we do have a lot of questions, as the other speakers have alluded to, and in summary to the answer of whether SpO2 in the first 10 minutes of life really matter, I would suggest maybe, and until we know better, to try to target a minimum SpO2 of at least 80% by 5 minutes of life. In real life, that's probably very difficult to do, and we still don't know what the best initial FiO2 is and whether the best SpO2 is the same for all infants. So please do consider joining our Torpedo and air studies and contact me. My email is up there. Thank you very much.
Thank you, Julie. This is fascinating work, and I see that there's a real movement toward personalization here, and you're finding the differences between the needs of boys versus girls, I think is just fascinating. So congratulations for this excellent work. Please keep it up. Our next speaker is going to be Vishal Kapadia. He is a NIH-funded clinical research scholar and associate professor of pediatrics at the University of Texas Southwestern Medical Center in Dallas. He also serves as a member of the International Liaison Committee on Resuscitation, Neonatal Life Support Task Force, and he's a member of the Neonatal Resuscitation Writing Group for American Heart Association and the American Academy of Pediatrics. And Vishal is going to talk about bradycardia and SpO2 in the delivery room as a prognostic factor. Vishal?
Yeah, thank you so much, Dr. Neo. Thank you, organizers, for inviting me. Let me load up my slides. Okay. Are you able to see my slides?
Yes, correct.
Okay. And it is in the slide mode, not the presenter mode, correct?
Yes, the slide mode.
Okay, perfect. All right. So I'm going to talk about heart rate as a prognostic factor, as SpO2 as a prognostic factor was just covered by Dr. Oy. These are my disclosures. Intrauterine hypoxia, or factors influencing physiologic changes during transition, can make a newborn limp, apneic, bradycardic. Many preterm infants experience suboptimal transition, producing bradycardia and/or apnea requiring resuscitation at birth. A rising heart rate is an important indicator of effective ventilation in a bradycardic newborn. If the heart rate remains below 100 beats per minute after the initial steps, the ILCOR guidelines recommend positive pressure ventilation. If the heart rate remains below 60 beats per minute after attempting adequate ventilation, the ILCOR guidelines recommend that we start chest compressions. Well, preterm infants who receive chest compression, we know this, that in the delivery room, if they receive chest compression, they have increased mortality and morbidity in survivors. Fortunately, most preterm infants with bradycardia respond to adequate ventilation, and very few require delivery room CPR. I would like to focus on the babies who do not require delivery room CPR. Does duration of bradycardia in such infants increase morbidity and mortality? It is unclear. As we just heard from Dr. Oy, our individual patient meta-analysis demonstrated that neonates who did not reach SpO2 of 80% at 5 minutes were more likely to die or develop severe IVH. Is this because sick infants are less likely to reach SpO2 of 80% at 5 minutes? Or is it because titration of oxygen can impact outcomes? We do not know yet, although it seems reasonable to avoid SpO2 of less than 80% at 5 minutes. Let's talk about another prognostic factor, which is prolonged bradycardia in the delivery room. Now, how bradycardia may cause adverse outcomes in newly born. Although there are other factors at play in a transitioning newborn, let's understand basic factors responsible for oxygen delivery to the tissues. The oxygen delivery to the tissues is dependent on oxygen content and cardiac output. Oxygen content depends on hemoglobin and oxygen saturation, as demonstrated by the equation over here. The other very important factor for delivery of the oxygen is cardiac output. Heart rate is critically important determinant of cardiac output and hence to the oxygen delivery to the tissues in a newly born infant. Newborn may be bradycardic at birth, either due to intrauterine hypoxia or poor pulmonary transition. Bradycardia may continue for a long period due to combination of severe insult and or inadequate resuscitation at birth. Prolonged bradycardia may compromise cardiac output and in turn reduce the delivery of oxygen to the tissues, resulting into tissue hypoxia and organ injury. Is there a relationship between the SpO2 and FiO2 and prolonged bradycardia? It is unclear if duration of bradycardia differs between preterms resuscitated with low versus high oxygen concentration. It is also unclear if prolonged bradycardia and low SpO2 in the delivery room have an additive significance on adverse outcomes. To answer these questions, we conducted a study called Bradycardia study. The objectives of the Bradycardia studies were follows. Determine incidence of prolonged bradycardia in preterm infants in the delivery room associated with neonatal morbidity and mortality. To determine association of prolonged bradycardia during neonatal resuscitation with neonatal morbidity and mortality, and to determine if there is an interaction between prolonged bradycardia and SpO2 during neonatal resuscitation for neonatal adverse outcomes. Randomized control trials, which recorded serial heart rate, SpO2, fraction of inspired oxygen during resuscitation of preterm neonates less than 32 weeks gestation, and those which titrated the FiO2 to achieve a target SpO2 were eligible. Individual patient data for infants less than 32 weeks gestation were obtained directly from the authors. Neonates without any heart rate data by 2 minutes or those who received chest compressions in the delivery room were excluded as per the published protocol. Patients were divided into 3 groups based on their heart rate data in the delivery room during the first 10 minutes of life. No bradycardia, that is heart rate more than or equal to 100 beats per minute throughout the first 10 minutes. Transient bradycardia, heart rate below 100 beats per minute for less than 2 minutes. And prolonged bradycardia, which is heart rate below 100 beats per minute for 2 minutes or longer. Primary outcome of this study was neonatal in-hospital mortality. Secondary outcomes were BPD, ROP, necrotizing enterocolitis, and IVH. We developed a search strategy and we searched databases such as Medline, PubMed, Embase, clinicaltrials.gov, Cochrane Control Trial Registers, and meeting abstracts from PAS, European Society of Pediatric Research, European Association of Pediatric Societies. And we searched those abstracts from 1990 to 2019 without language restrictions. We use index terms, preterm, resuscitation, and oxygen. We analyze risk of bias using Cochrane risk of bias tool, and certainty of evidence was assessed using GRADE framework. We conducted 2 types of data analysis. Individual patient data analysis, which I think is the strength of the study. We looked at, we got individual patient data from the trials that were included in the systematic review. And we looked at the association of bradycardia with neonatal morbidity and mortality in this individual patient data. And we also conducted multivariate stepwise forward logistic regression to account for confounding variables. The second type of analysis that we conducted was pooled data analysis. Here we pulled all the data together and conducted from aggregate data per study to compare neonates with prolonged bradycardia with those without prolonged bradycardia. We will present unadjusted summary odds ratio and corresponding 95% confidence intervals using Mantel-Haenszel method for dichotomous variables. And forest plots were used for the graphical representations of the odds ratios generated from unadjusted data. What are the results? So this is the Prisma flow diagram of the Preterm study. And as you can see from the extensive searching through the abstracts and full text, we ended up with about 8 studies, which were included in the systematic review and meta-analysis. And here are the studies included. As you can see, the various studies started enrolling from 2005 to 2014. These are the studies from US, Spain, Canada, Netherlands, Australia, Malaysia, Qatar. FiO2 groups were different. Some studies compared 21% to 100%. Some studies compared 30% to 90%. Some studies compared 30% to 60%. Total of 605 babies were included in this Preterm study. When we assess risk of bias, all the studies fell under unclear risk of bias except Rabi et al., which fell under low risk of bias. Let's first focus on analysis of the aggregated individual patient data. 42% of the babies did not have bradycardia, but interestingly, what that means is that about 58% of the babies at birth had bradycardia, and about 38% of the babies had prolonged bradycardia. Remember, it is defined as heart rate less than 100 beats per minute for 2 minutes or longer. Looking at the gestational ages, of course, the babies who had prolonged bradycardia had lower gestational age and had lower birth weight, although there was no difference in sex. What are the patient characteristics? There was no difference in antenatal steroids or rates of cesarean section. One of the interesting thing that we wanted to look at is that does starting low FiO2 influence whether the babies have prolonged bradycardia or not? And we found that there was no difference. But interestingly, the babies who had prolonged bradycardia were also more likely to have SpO2 of less than 80% at 5 minutes. And of course, the babies with prolonged bradycardia had lower APGAR scores at 1 minute and 5 minutes of life. What about clinical outcomes? As Max had alluded to, we found that the babies with prolonged bradycardia were more likely to die. And this association remained significant even after adjusting for gestational age. They also were more likely to develop IVH or death or IVH, and this association also stayed significant even after adjusting for gestational age. They were more likely to develop BPD, but that significance did not stay, p-value did not stay less than 0.05 when we adjusted for gestational age, and NEC and ROP rates were no difference across the 3 groups. Of course, this is a retrospective study. We need to control for the confounding variable. So we did a multiple logistic regression. We controlled for gestational age, male gender, birth weight, antenatal steroids, individual study as there was heterogeneity, and then SATs of less than 80% at 5 minutes after birth. After controlling for all these confounding variables, prolonged bradycardia was still significantly associated with in-hospital mortality. Even more interestingly, and shows that there is a stronger association, is that we found exposure-response relationship. What does that mean? So on x-axis, we have duration of bradycardia after birth, and y-axis, we have mortality before discharge as percentages. This is the reference group. These are the babies who did not have any bradycardia for the first 10 minutes of life, and their odds of dying before discharge were very low. But as the duration of bradycardia increases for the first 10 minutes of life, the odds, the percentage of babies who die increases. And as you can see, if you have bradycardia for 6 minutes or more, remember, none of these babies received chest compression. Their heart rate stayed between 60 and 100 beats per minute. They had very high odds of death and its strong association with duration of bradycardia. Let's look at pool data analysis. When we did the pool data analysis, and I'm demonstrating the unadjusted data with forest plots, we found that there is a higher in-hospital mortality with prolonged bradycardia. The summary odds ratio was 3.79 with confidence interval of 1.55 to 9.28. There was no association between initial low FiO2 and prolonged bradycardia. Interestingly, when we looked at, we wanted to look at whether there is an interaction between prolonged bradycardia and saturation of less than 80% at 5 minutes for mortality. Let me walk you through this figure. So on x-axis, there are three groups: no bradycardia, transient bradycardia, and prolonged bradycardia. On y-axis, we have odds of mortality. The blue bars, they indicate the odds of mortality in infants with SpO2 of more than or equal to 80% at 5 minutes in the corresponding bradycardia group, while the yellow bars indicate odds of mortality for newborns with SpO2 of less than 80% at 5 minutes in the corresponding status of bradycardia. For this analysis, remember the reference group is this group, that these babies have no bradycardia and they have good SATs of more than equal to 80% at 5 minutes of life. And that's your reference group. If you compare to this reference group, other groups, you can clearly see that there is an additive interaction between prolonged bradycardia and SATs of less than 80% at 5 minutes of mortality. So compared to this reference group, the preterm infants who had both prolonged bradycardia and SATs of less than 80% at 5 minutes after birth had odds in-hospital mortality were 18 times higher. And this odds ratio, 95% confidence interval was about 4% to 79%. So these babies are at very high risk of dying in the NICU. And this positive additive interaction persisted even after we control for the gestational age. So in summary, 38% of preterm infants less than 32 weeks gestational age experience prolonged bradycardia in the delivery room. Prolonged bradycardia is associated with in-hospital mortality and severe IVH. There is an exposure-response relationship between duration of bradycardia and mortality. Highest odds of in-hospital mortality were in preterm infants with prolonged bradycardia and SpO2 of less than 80% at 5 minutes. No association between resuscitation with low FiO2 and prolonged bradycardia. This data is limited, as in we cannot claim causation, right? There could be an unaccounted confounding, such as babies with prolonged bradycardia might be the sickest babies, and that's why you have higher odds of death. We have tried to account for those confounding using logistic regression, but that could be an unaccounted confounding. It's a small sample size, even though 605 babies were studied. There was heterogeneity between studies. There was no description of delayed cord clamping, so we couldn't differentiate which babies got delayed cord clamping and which babies did not. As we know that delayed cord clamping, baby SATs are higher and the heart rate could be better. And none of the studies used ECG to measure heart rate, as we know that pulse oximetry tend to underestimate heart rate. It is unclear if the heart rate measured by ECG based on cardiac electrical activity or by pulse oximetry, which is based on peripheral pulse, which one is the better measure of cardiac contraction and circulation of blood to the peripheral tissues. But such studies should be repeated with ECG data. In conclusion, prolonged bradycardia and SpO2 of less than 80% at 5 minutes in the delivery room are associated with adverse neonatal outcomes and should be avoided. Importantly, duration of bradycardia should be reported in all relevant resuscitation studies, as I think it is a very important prognostic marker. It remains unclear if improving non-invasive ventilation in preterm infants will decrease the duration of bradycardia and in turn improve neonatal outcomes. So I'm looking forward to such studies. And more prospective studies should be done to examine these factors associated with adverse outcomes. These are the group of investigators that I was fortunate to work with. It's a diverse group of investigators who guided me through this study. And as this figure on Dunning-Kruger effect shows, that we are still learning. So I thank you, and I'm happy to participate in the discussion later on.
Thank you, Vishal. I think that this is a very important variable that we need to consider in the future. And looking forward very much to your future studies in this area. Thank you very much. So Gianluca, I think you are going to present the next speaker.
Yes, now we move to the last but not least speaker. I'm very happy to introduce Professor Satya Maximi Russima. He's a professor of pediatrics, is a pediatrician-in-chief at Davis Children's Hospital, University of California. He's very active in clinical research about the neonatal hemodynamics in pulmonary hypertension. And I think it could be very interesting to listen his presentation about the oxygenation beyond the delivery room. Please, Satya.
Professor Lister, Professor New, thank you very much for the invitation, and I hope you're seeing my slides.
Yes,
okay. So I will talk about oxygenation outside the delivery room. We heard elegant talks about what to do in the delivery room, and now let's talk about what to do outside the delivery room. I will also briefly talk about appropriate targeting, because that seems to be a major question once you get the baby out of the delivery room. So here are my disclosures. So we talked about what happens during delivery, during resuscitation, and I will focus mainly on post-resuscitation and divide the data between preterm infants and term infants. Interestingly, while there is a lot of information and lots of controversy in preterm infants during resuscitation compared to term infants, the opposite is true once you bring the baby to the NICU, because there are studies evaluating what to do in preterm infants, but there are hardly any studies evaluating what to do in term infants, especially term infants with pulmonary hypertension. So therapy with oxygen is very common. Anytime we walk into the NICU and we see a baby having low saturations, the immediate reaction is to increase FiO2 and make the baby have better saturations. So why do we do that? So we do that to make sure there is adequate oxygen delivery to the tissues, as Ola mentioned earlier. And oxygen delivery to the tissues is based on blood flow, hemoglobin, and the oxygen content in the blood. So this is a classic physiology curve where oxygen delivery to a given tissue is usually somewhere between 3 to 4 times the oxygen consumption. And so we are all in this nice safe zone. But if our oxygen delivery gradually goes down, as you see maybe with anemia or with reduced blood flow, you reach a critical point below which reduction in oxygen delivery results in a reduction in oxygen consumption. So you enter a phase called delivery-dependent oxygen consumption range. And once you get to this range, if you reduce your oxygen delivery, you reduce your oxygen consumption. And if it goes further down, down, and down, you'll end up with negative effects of ischemia, lactic acidosis, and eventually you will die. On the other hand, how do we figure out how much O2 to give? The upper limit probably is where you reach oxygen toxicity, and that's a very variable number. And Ola showed what happens in mitochondria with high oxygen levels. The lower limit is probably something that's a little more clear, because you really do not want to go below your critical point, and you really do not want to cause hypoxic pulmonary vasoconstriction. So these are the two factors that determine the lower range of what is considered normal for oxygen saturations. So let's talk about hypoxic pulmonary vasoconstriction first. I mean, this is a time of COVID, and we are all worried about acquiring pneumonia. And if a patient acquires, say, for example, a lobar pneumonia, and there is no point in wasting blood going to the lung. And so what the body does is, if you have a diseased alveolus, there is adjacent hypoxic vasoconstriction, thereby limiting the amount of blood supply to this area. So diverting blood to the normal areas, thereby leading to ventilation perfusion matching. And this phenomenon is present in pretty much all mammalian species. So what causes hypoxic pulmonary vasoconstriction? This has been answered by Professor Rudolph way back in 1966, before many of us were born. And what he basically showed that there was an entity called as a change point, approximately 45 to 50 millimeters of mercury, below which you cause hypoxia. This graph also shows that hypoxia clearly causes pulmonary vasoconstriction, and normoxia, maintaining PaO2 somewhere between 60 and 80, causes pulmonary vasodilation, but hyperoxia, maintaining PaO2 above 100 millimeters of mercury, does not cause any additional pulmonary vasodilation. So this is great. But Dr. Rudolph also showed another curve, which is probably even more important, where he showed that this particular change point that he was talking about of approximately 55 millimeters of mercury, on the other hand, if you had a combination of acidosis, say your pH was 7.1, this change point was much higher. Below 55, you started seeing hypoxic pulmonary vasoconstriction. In addition, the degree of hypoxic pulmonary vasoconstriction was much more exaggerated by hypoxia. On the other hand, if you had normal pH, these numbers were much lower and things were very different. So when you look at studies, it's really important to see, are you treating a baby with severe lung disease with acidosis, in which case you probably need higher saturations. On the other hand, if you have a reasonably normal pH, for example, a baby with TGA who is hypoxic, that baby might have a different cutoff for causing hypoxic pulmonary vasoconstriction. And this is the reason why, at least initially, many patients with cyanotic congenital heart disease do not suffer from hypoxic pulmonary vasoconstriction because their pH is normal and their alveolar oxygen is normal. So these two are very different entities. So where exactly should we worry about PO2? Should we worry about preductal, postductal? What should we worry about? What really dictates pulmonary vascular resistance? If you think of this figure, and here is the heart, and here is the pulmonary artery, and here is the pulmonary vein, and the alveolus is here, the area that really determines hypoxic pulmonary vasoconstriction is this precapillary pulmonary arteriole, and this is the main area where PVR is determined. This is determined predominantly by alveolar PO2, which is uppercase APaO2, and alveolar PaO2 dictates how much oxygen is present around this arteriole. And since we cannot measure alveolar PaO2 accurately, we take pulmonary venous PaO2 to be a surrogate. And since we can't measure this either, we equate that to the preductal pulse oximetry. And that's the reason why it's important to monitor preductal pulse oximetry while you adjust FiO2 in these patients. The second determinant is pulmonary arterial PVO2, because that accounts for approximately a third of pulmonary vascular resistance. And that's a number that's kind of dependent on mixed venous PVO2. And these are the two factors that determine pulmonary vascular resistance. But Julie briefly mentioned that hyperoxia can decrease blood flow to the brain, and that's an important entity. Similarly, hypoxia can decrease blood flow to the lung. And Professor New has done a lot of work on the intestines and neck, and we clearly know that hypoxia decreases blood flow to the intestines as well. So every day you and I work in the NICU, we are walking a tightrope balance, trying to determine the optimal oxygenation. And this is a delicate balance between cerebral and retinal oxygenation and pulmonary oxygenation, and of course, the intestinal oxygenation. So Vishal has shown elegantly the importance of avoiding hyperoxia from a brain standpoint. And in this really nice study, what he did was he took a bunch of patients who are at risk for developing HIE, and he monitored the first blood gas in these patients and looked at their PaO2 values. And what he found was that if the first arterial gas had a high PaO2 value, then the risk of these babies developing hypoxic ischemic encephalopathy was increasing. And this goes to show that when you have a combination of perinatal asphyxia along with postnatal hyperoxia, you land up with increased incidence of hypoxic ischemic encephalopathy. And the cutoff is somewhere probably in the 100 millimeters plus range. So it's important to avoid PaO2 above 100 millimeters of mercury range in the immediate postnatal period, which seems to be a very sensitive period in many babies. But when you really look at what happens in real life, these are data from the Neonatal Research Network. All the babies who were looked in or evaluated in the clinical trials for hypothermia, therapeutic hypothermia. In fact, when you look at the baseline gases, most babies, in fact, have PaO2. The median PaO2 in this study was actually somewhere close to 130 to 140 millimeters of mercury. So in real life, we maintain fairly high PaO2 values in these babies for unknown reasons by giving a lot of oxygen. If you look at babies with PPHN, they were getting somewhere around 80% oxygen to maintain PaO2 above 100 millimeters of mercury. So we give a lot of O2 to these babies and maintain their PaO2 in pretty high range. So what should we really do? What do the guidelines say? The guidelines clearly tell us to focus on preductal oxygenation. And the range recommended is 91 to 95%. And they really tell us that we should not worry about post-rectal oxygenation, although this is not an easy thing to do. Some of the nurses will get very upset when the oxygen saturations are low, and sometimes maybe justifiably. But we need to really make sure that the lactate levels are normal and the urine output is adequate. So the current European Pulmonary Vascular Disease Network guidelines suggest that in term or preterm newborn, receiving oxygen, ventilator support, or surfactant is needed, the prerectal O2 should be maintained between 91 and 95%, and we should avoid SATs below 85 and avoid SATs above 97. So this is the range, 91 to 95, that's recommended in patients with pulmonary hypertension. But do we have any basis for this? There is no human data to support that piece of information. What we have is animal data, and in animals, different models that I have studied in the past, lambs with pulmonary hypertension induced by ductal ligation, meconium aspiration, and asphyxia, or control lambs. What you see in these studies is that when you maintain SATs between 90 and 97 or 98%, the oxygen saturation in this range results in low pulmonary vascular resistance, justifying what the European network is suggesting us to do with saturation ranges. But those lambs, as I mentioned here, mostly had normal pH. And when we look at more deeply in lambs that are a bit sick with slightly higher PCO2 values and slightly low pH values, this is what we find. So here in this graph, you have achieved preductal pulse oximetry in lambs with meconium aspiration and asphyxia. And these are the 4 oxygen saturation ranges that these lambs achieved. When you look at their PO2, the PO2 is really low, the red squares with low saturations, somewhat equal between 90 to 94 and 93 to 97. But when you target 100%, you see a huge increase in PO2 levels. And here is the FiO2 that you require to achieve these PO2 values. What is even more interesting is that when you target 90 to 94% in the presence of a bit of acidosis and lung disease with low FiO2, the PVR is fairly high. On the other hand, when you target mid-90s, the PVR drops really well, but these lambs require slightly higher inspired oxygen. So inspired oxygen is also an important component, giving around 40 to 45% O2 in these really sick lambs with acidosis and lung disease, and maintaining PaO2 slightly higher helps in drop in pulmonary vascular resistance. So the targets that we use differ from when you have somebody with normal pH versus somebody that has significant acidosis. So these are the 2 ranges that we need to think about when we think of patients in the outside the delivery room. The next controversial area is therapeutic hypothermia. Many patients in our unit, and this is the standard of care right now, that have hypoxic ischemic encephalopathy undergo therapeutic hypothermia. And hypothermia does cause an increase in FiO2 requirement. It does cause increase in pulmonary vascular resistance. And interestingly, it shifts the hemoglobin oxygen dissociation curve to the left, thereby altering the relationship between PaO2 and SpO2. Let me show this to you in this graph. So here is a graph where we collected data from close to 500 blood gases and plotted temperature-corrected PO2 values on the horizontal axis and pulse oximetry on the vertical axis. And what we saw was that if you maintain SpO2 in the usual low 90s, when the patient is normothermic, you do a great job and you maintain PaO2 between 50 and 75. On the other hand, during hypothermia to 33.5 degrees centigrade, there's a shift in oxygen dissociation curve to the left. And in this particular instance, to maintain the same normoxic range between 50 and 75 millimeters of mercury, you actually need fairly high saturations, somewhere close to 97% range. So the optimal range for pulse oximetry changes between normothermia and hypothermia. And this is something to remember when we are cooling babies with severe PPHN, and these babies are on the verge of ECMO. In these instances, you may need to target SpO2 in the mid to high 90s and not in low 90s to maintain normoxemia. So we talked about term infants. What about preterm infants? Dr. SAUGSTAD showed this slide. The Neoprom trials have addressed the topic on optimal target SpO2 in preterm neonates that would result in low death or neurodisability. Trials have been done in the US, Canada, New Zealand, Australia, and UK, and have been published. And basically what the studies show that if you target 85 to 89%, the combined outcome of death and neurodisability is 53.5%. If you target 91 to 95%, the same combined outcome is 51.6% with no difference between the two groups. On the other hand, if you target the low range, there's an increased incidence of necrotizing enterocolitis. Remember, hypoxia causes intestinal vasoconstriction, and that might be something that's playing a role here. There is increased mortality. There is increased need for PDA requiring ductal ligation. On the other hand, if you target higher SATs, there's increased incidence of ROP with no change in blindness, and also increased need for supplemental oxygen at 36 weeks postmenstrual age. Because of these results, especially with the result of 93%, and subsequently now most units have increased their target to somewhere between 90 to 94% because of this concern about mortality. But these interpreted with a bit of caution. It's not purely oxygen. Here is a slide that Ola and Dr. Manja put together where they showed that spending more, these bars, the amount of time you spend below 85% in each individual study, and the gray bar. So there are some studies where you spend a lot of time below 85% range, but the mortality is lower. And there are some studies where you don't spend a lot of time below the 85% range, but still the mortality is higher. So there appears to be a disconnect between mortality seen in these studies and the actual patient. Here is that if you look at the studies that started randomization really early, less than 6 hours, in these babies, in the individual meta-analysis done by Lisa Askey and her colleagues, what you see is that in these studies where the randomization was achieved less than 6 hours, there was a significant difference in mortality between the lower target group and the higher target group with a p-value of 0.027. On the other hand, when you look at patients who were randomized after the first 6 hours, you see no difference in mortality between the two groups, showing that the immediate postnatal period for the first 6 hours might be a crucial period, similar to what Vishal showed in his term baby trial. The second issue is that these alarm limits, if you consider a preterm baby to be a car on a journey from in the NICU, and the lane in which the baby has to stay are the target range, and these rumble strips that you see at the ends are the alarm limits, and you use pulse oximetry and blood gases to monitor. And this is the hyperoxia, and here is hypoxia. In this range, if you have a reasonably wide target range, it's easier to maintain the car within the lane. On the other hand, if the lanes are really narrow, as was present in 85 to 90% target or 90 to 95% target, it's very difficult to spend adequate time within these ranges. And in fact, with the support trial, what you saw was that the babies randomized to the lower target spent only 26% of their time in the low target range and close to 50% of their time in the high target range. So spending longer time within the target range is important, and having a very narrow target range makes it difficult for the nurses to maintain babies within those limits. And one way of bypassing that is to use automated FiO2 monitoring, where the oximetry sensor is connected to an oximeter module, which in turn is connected to the oxygen blender in the ventilator. So the machine automatically adjusts FiO2, and there are some ventilators that are currently available, although I personally don't have a lot of experience with them. And Souvik Mitra has shown in a recent systematic review that with automated control, you achieve a lot more time within target saturation range compared to manual control. And so this might be a way of future, and this is something that we may be using a lot more for monitoring babies in the NICU and adjusting their FiO2. So what else could be the reason for increased mortality? The interesting finding in all the Neoprom studies, especially the support trial, is that the difference in mortality between the low target arm and the high target arm does not happen for the first 3 weeks. It happens after the first 3 weeks. And Max has come up with an interesting hypothesis in one of his reviews, suggesting that maybe with the decreased hemoglobin that you'd observe with prolonged time, maybe this low hemoglobin in combination with low pulse ox causes this change, which is very plausible. For example, if you're maintaining hemoglobin at a higher level and your oxygenation levels are slightly dropping, you still are above the threshold for hypoxemia. On the other hand, if you let the hemoglobin go too low, and then you maintain pulse ox in the 85 range, you might be falling below this threshold, causing hypoxia and increased mortality. But this was partly refuted by the TOP trial, where Harish Kriplani and colleagues showed that when you randomize babies to either higher threshold or lower threshold, there was no difference in death or neurodevelopmental disability, and no difference in death between the high threshold hemoglobin group and the low threshold hemoglobin group. But there are two things important to remember here. The low arm in the TOP trial still maintained hemoglobin at a median of around 8 grams or higher. And taking hemoglobin much lower than 8 grams is probably something that we shouldn't be avoiding. And the second thing is that the TOP trial was conducted in the US after the completion of the support trial and the Neoprom trials. So most units, I presume, used higher saturation ranges. So we could not really test the combination of low oxygen saturation and low hemoglobin in preterm infants to check this hypothesis. So to conclude, we have seen that in preterm infants, maintaining pulse oximetry in the low 90s is probably adequate. In term infants, although we do not have a lot of clinical data, animal studies suggest that maintaining SpO2 in the mid 90s is probably adequate, except during hypothermia, where you might need higher saturations. There are plenty of studies now showing that in the PICU, in babies, in infants and post-neonatal infants with bronchiolitis, maintaining saturation between 90 and 94 appears to be reasonable compared to maintaining saturations above 94. And in fact, there are lots of new trials, one more recent one that came out a few months ago, where in adults, they have shown that in ST segment elevation myocardial infarction, in ARDS, using saturation ranges in the mid 90s is preferable to maintaining saturation ranges in the high 90s. And in fact, although we say that children are not small adults and neonates are not small children, there appears to be something that binds all of us. Maintaining saturations in the mid 90s is something that will keep us healthy reasonably when we need supplemental oxygen with lung disease. So to conclude, hypoxia can be natural, but hyperoxia is always iatrogenic. Unless you and I give oxygen to babies, there is no normal mechanism of hyperoxia. And both hyperoxia and hypoxia are associated with adverse events. An SpO2 range of 91 to 95% or slightly 97% at the upper limit appears to be suitable for most circumstances in the NICU. And other than just targeting on SpO2, maintaining optimal hemoglobin, pH, and blood flow through optimal PaCO2 management can influence oxygen delivery to the tissues, and optimal oxygenation is a balance of competing outcomes. I thank you for your attention, and I'm happy to join the panel to take questions. Let me stop sharing my screen.
Thank you, Satya, for your excellent presentation and the interrelationship between oxygen and hemodynamics. I don't know how many minutes we have for discussion. Ask Hola and Joseph and Corrado. One question for each talk or no? I will decide. Hola. Corrado, we don't hear you.
I think we can start with the question of the of the participants.
I already answered my questions on the chat. I had 7 or 8 questions, which I already answered. So the answer is written. I don't know if you want to comment on that.
Joseph, want to start with Ola?
Yes, so there is one question for Ola, and this is on the epigenetic changes in the animal model after hyperoxia. Are these epigenetic changes reversible in this animal model?
Well, that's a very good and important question. And as far as I know, nobody can answer that question. Of course, it's concerning if this is permanent and may have lifelong consequences. And I think the only way to find that out is to do longitudinal studies. So I'm not aware of any such studies. I don't know if anyone in the panel could answer that.
I could, sorry, I could, we did a study that Ola presented in which we correlated the oxygen load of these babies, preterm babies, with epigenetic changes. And we followed these babies, and we are now going to get the paper sent for publication. and only few of these changes remained after 2 years. But we just measured the oxygen load, so we don't know if there are other circumstances that could have influenced the permanence of epigenetic changes.
Okay, we have another question here, and I think that this is a very interesting one. How does high oxidative stress status manifest clinically? It's not for anybody in particular, but any one of our speakers.
I will take a shot at it. Unfortunately, clinically, it's not easy to figure out the effects of hyperoxia. And that's one of the issues we are facing because there is not a physiological or a clinical equivalent that clearly dictates what happens with hyperoxia. The main side effects that we see is actually what Julie mentioned, which is reduced blood flow to the brain. That's something that we start seeing when the PO2 levels go up in many animal models, and that's something that we should remember. So this is not something that can be clinically detected to my knowledge. So this is a tricky part as to how we figure this out.
Okay, thank you. There's another question about providing chest compression as soon as we find the heart rate less than 100 at any time during resuscitation.
Yeah, so I'll try to answer that. And I think Satyan is also can follow up on this. It's interesting. The evidence behind starting chest compressions when the heart rate is less than 60 beats per minute is, I think, based on expert consensus rather than any evidence. Although there are studies in pediatric literature where in PICU, when they did chest compressions with pulseless bradycardia, they actually had worse outcomes. That is, you have to be careful because when you are doing chest compressions, the purpose of the chest compression is to provide the blood flow to the brain and provide the blood flow to the heart. And when you are trying to do chest compressions, when you already have an innate rhythm, you can actually cause more harm, such as you can have a problem with the preload, problem with the pulmonary blood flow. You can cause and we have to deal with open ductus. So there is also a chance that could be retrograde flow. So there are chances of causing harm of doing chest compressions, which is not in sync with the innate cardiac rhythm. And that's why one needs to be careful. I think Praveen, one of the investigators with Satyen, they are looking at heart rate and when should we start chest compressions. And I think those are the studies which are funded by also NRP. So I'm really looking forward to those studies and results. If you are interested in that, you can actually look up those articles under Dr. Lakshmi Russima's name, and I think Praveen Chandrasekharan. Satyan, you want to add something?
Thanks, Vishal. What you said is absolutely right. The current recommendations obviously are not to start chest compressions for a heart rate of 100, and it's less than 60 after achieving optimal ventilation. And early initiation of chest compressions actually does a lot of harm. As Vishal mentioned, the beautiful heart beats so synchronously and increases blood flow to all the organs. And when you try to compress the heart, the amount of blood flow that you generate is really marginal. So trying to compress a normally beating heart really causes problems. So we should really not be doing chest compressions when the heart rate is above 60, and only below 60 when blood flow to the organs is extremely compromised. That's when it's indicated. So I think Praveen has a really nice abstract that he will present at PAS this year with some of the results showing the harm from chest compressions when you do it really early at higher intrinsic heart rates.
Yeah, I think focusing on ventilation and improving ventilation will correct many of these babies who are staying between 60 and 100. And we know that non-invasive ventilation skill is a complex skill. We need to do better at training people in doing a better job at ventilation.
But do you know if some techniques can be better compared to others for improving non-invasive ventilation? If I don't know, nasal bronch is better than TPs or laryngeal mask? There are some data to give suggestion to the participant, which could be the better
So
way.
we at ILCOR, we looked at different devices and different interfaces. And I think that is just like a couple of days ago, I think it is published for the public comments, that systematic review. We did not find a difference between different devices or different interfaces. There is a lot of research, I think, which will come in coming 5 to 10 years about different interfaces. One of the things that we deal with the face mask ventilation is the mask leak obstruction. How do you recognize it? How do you avoid it? How do we train people in recognizing and avoiding it? Should we, and also more and more recognize, I think, from some of the studies from Europe is the impact of trigeminal cardiac reflex. When you are ventilating, there could be closed larynx and you are trying to ventilate, you are just doing the pharyngeal inflation rather than really putting air into the chest. So a lot of studies, I think, will come. Right now, I believe, is that do one thing, do it well. If you are doing face mask ventilation in your hospital, train people to recognize mask leak obstruction, pay attention to chest rise, pay attention to your heart rate and SpO2 while we await more studies.
Can I use a question that there is in the list, but just a little bit changing. So the question is, could we imagine strategies or resuscitation delivery room depending on the fetus condition, especially during the few pre-birth minutes? Fetal bradycardia, uterine rupture, vasolective, repeated cesarean section. And I wanted to do another question. How much is important the prenatal study? Neonates, severe UGR, in terms of decision to use a different strategy of saturation, different strategy of FiO2. It's open for all the speakers.
First, I could try to ask the second question. Yeah, I think this is very, very important. In fact, when we analyze our data we always mention that babies who don't reach saturation of 80 in the first minutes, this could be either that we are not using the correct parameters of ventilation, FiO2, etc., or that the baby was already sick in utero and the standard procedures that we are applying are not enough. So this is something that should be taken into account. And I think individualization of resuscitation is going in this direction. A baby who starts with 0.3, 0.4 FiO2 with positive pressure ventilation and does not react, and heart rate doesn't increase, and SpO2 doesn't increase, it can be both. It can be either we are not doing the correct position of the mask or other parameters, or the baby is so sick that he needs to go rapidly into higher oxygens and higher pressures in order to be recovered. So this is something to be taken into account. So when you are resuscitating a baby that has antecedents of being very sick in utero, you should be prepared to change your parameters more rapidly than when there are any antecedents of in utero conditions.
There's another question. Studies have shown that nurses keep saturation the higher limit of alarm set. Should we take this into consideration when setting alarms? Who wants to answer?
I'll take that. The funny thing with oxygen saturation, oxygen dissociation curve is that at the higher range, the curve gets flatter and flatter. So it's actually a little easier to maintain saturations in the higher range. And there's a general tendency, we all love oxygen, and Ola has tried to pull us away from that love, but we still love oxygen. And it's an innate tendency in us And Barbara Schmidt has shown elegantly in the CART trials that there is this tendency to increase FiO2 towards that range, resulting in higher saturations. So I don't think we should take that into consideration. I really think automated FiO2 is an important thing we need to pursue. And second, maintain alarms. And I think we have learned a lot following the Neoprom trials, and most of us tend to target SpO2 in the low 90s or maybe high 80s for the lower alarm limit, and mid 90s to 96% for the upper alarm limit. And that seems to be helpful for us. And I think nurses, and I mean, we usually comment on nurses, but I have tried spending 6 hours next to a baby's bedside, and I can't keep the saturations in that range either with nothing else to do. And the nurses do 100 other things when they're trying to maintain these saturations. So it's very difficult to do this. So we really need to look into automation and coming up with slightly wider ranges, which are easier to maintain at the bedside than extremely narrow ranges.
I think I would just add one thing to that is that while we await for the automation, I think avoiding extremes is, I think, very important. So if you look at the data and if you look at the distribution, it's a bell-shaped distribution, and many times the adverse effects are happening when there is a thick tail, when there are extreme saturation values beyond your target range. So I think avoiding extremes and not necessarily worrying about 1 point away from your goal range, but I think extremes might be more harmful. But yeah, looking forward to the studies of automated FiO2, not only in the beyond the delivery room, but there are some studies going on even looking at in the delivery room for the automated oxygenation.
I don't know how long time we have because we have 10 minutes past 4. Corrado, what do you think? We have to close, Ola?
Oh, Fabio, do we have some more time? Because there are some more questions.
I guess you can take other couple of questions.
Let me just, there's one question here from Romania that I think is very interesting. In the resuscitation of premature babies under 32 weeks, when you use NeoPuff, how long do you use this? And how long do you leave until the umbilical cord is clamped?
So I will start with the answer. So if I understand correctly, the question has 2 parts. One, if you are already attached, newly born baby is still attached to the umbilical cord and to the placenta. At least in American guidelines in US, we do not recommend yet resuscitation on intact umbilical cord. Our guidelines suggest that when the baby is born, which is full expulsion of the body from the mother, you assess the baby at that time. You can perform initial steps maybe while the baby is attached to the umbilical cord. But at that time, if you find that baby is non-vigorous, hence baby is limp, baby is not breathing, baby does not have good heart rate, then in American guidelines, we recommend that we clamp the cord, bring the baby to the radiant warmer and start resuscitation. So that's one part. The second part, I think, relates to how long do you continue resuscitating with NeoPuff if the heart rate is still low, and when do you move on to invasive modalities such as using LMA or using an alternate airway. And I think American guidelines dictate that you perform ventilation corrective steps, which is Mr. SOPA steps, at the end of the P, when you have increased the pressure and you are still not seeing effective chest rise, or your heart rate is still less than 100, then at that point you should move on to the alternate airway, which could be a supraglottic airway or an endotracheal tube.
Hola, there is an interesting question for you. Is the epigenetic changes in the animal model after hyperoxia irreversible? This is a very interesting question because oxygen tension is critical regulator of lung growth during fetal life. And the hyperoxia inhibits the signaling necessary for normal lung growth. So this is a very interesting question because I don't know if you can do a comment.
Well, yeah, I think we commented on that already, and I said that we don't know, and Max went to have some new data indicating that after 2 years, maybe at least part of these changes are reversible. But I think it's an important, very important question, and I think we have to do really longitudinal studies, and then I'm not talking about 2 years, but 20 years, 30 years, 40 years follow-up. And that will obviously be after my time. So I hope some of the young among us can try to do such studies.
Because if I am not wrong, many genes that control the development of the lung and of the airways are activated by hypoxia during fetal life. But preterm birth per se is hyperhypoxia. And so the development of the lung is altered. And this stimulation of the genes by hypoxia is due to the so-called hypoxia-inducible factors. And I read that these could be useful targets for alveolar regeneration. This is the future. And I don't know if somebody of you can comment this.
Well, we have done several whole genome studies in newborn mice resuscitated with different oxen concentrations. And I don't have time to summarize these data here, but I think we find quite interesting, some interesting results. Yes. Maybe Joe, you can comment on that better than me.
I have not done studies in that area, but I think that is just a fascinating area to look at the epigenetic changes, and I think that the work that is being done in that area is fascinating.
Right. This is, moreover, is a very complex topic. I think that we can close here this wonderful webinar. And I really want to thank you, all of you, for your collaboration. It was a very wonderful webinar. So thank you, Hola. Thank you, Vishal. Thank you, Julie. Thank you, Joseph. Thank you, all of you.
Thank you, everybody.
Thank you, Corrado. Thank you, Joe.
Grazie.
Yeah, of course. Thank you, Joe, and thank you, Ola. Giancarlo, auguri.